Good evening, everyone, and welcome for today's Med Talk session. I am Adafshin, your moderator for this program. A very warm welcome to all the respected all participants on today's Med Talks. Today's topic of discussion is incidentally pick up fatty liver on health checkup. With the increasing prevalence of lifestyle related disorders, fatty liver is being detected more frequently, often incidentally during routine health screenings. Understanding its implication, risk, and management is crucial for both patients and clinicians. It is my honor to introduce our speaker, Dr. Abha Nagral. She is the doctor and Department of Gastroenterology at Jaslok Hospital and Research Center in Mumbai. She is also the founding trustee of Children's Liver Foundation. She is a chairperson of the Liver Subcommittee at ZTCC Mumbai. She is Liver Committee member at ROTTO at chairperson of the South Asian Association for Study of Liver Women's Forum. With her vast expertise and leadership in the field of hepatology and liver transplantation, we are privileged to have her with us today. I now invite ma'am to deliver her talk. Ma'am, this is over to you.
Thank you. Thank you, IJCP, for this invitation. So I think we are already a little late. Let us start. So I'm going to talk about a 25-year-old IT professional. This is the patient we are discussing today. And this is what we very commonly see in practice, who goes for a corporate health checkup. He weighs 80 kilos. His height is 164 centimeters and his BMI is 29.7. His waist circumference is high, 40 inches. His blood pressure is incidentally found to be 155 by 100. So far, he's had no liver disease or any other disease for that matter. His ultrasound abdomen shows a fatty liver on the health checkup. Also, his liver function test, ALT 104, AST or SGOT 98. Rest of the liver biochemistry is normal. His HbA1c is 77.2, which is again in the diabetic range, and his lipid profile is also grossly abnormal. So he has been incidentally picked up. He's come without any symptoms, but he's got picked up with hypertension, fatty liver, raised liver enzymes, diabetes, and dyslipidemia. So he started on amlodipine, metformin, rosuvastatin, amlodipine for his hypertension, metformin for the diabetes, and rosuvastatin for the dyslipidemia. He's given a 2-minute brief on diet and exercise and said that is he should follow that. He's given a chart, and he's asked to go and see a dietitian or a nutritionist. Now, when we come to the patient's habits, he drinks 3 beers thrice a week, more on weekends. He lives with friends because he's gone to another city, often eats and drinks out during client meetings, smokes socially, works from home 50% of the time, and travels by car. Has late nights, sleeps late, gets up late, usually watches Netflix while sleeping, and while he's watching the shows, he's snacking on chips, chioda, and whatever comes on hand. He also has been told that by his friends that he snores loudly, does not sleep soundly, does not feel fresh when he gets up first thing in the morning. Now he has made attempts for a better lifestyle to lose weight. He keeps going through Instagram to see what can be done to lose weight. So he's tried several things. He takes warm water with lemon in the morning. He's had coffee with ghee. Somebody is told that's a good idea. He's even tried intermittent fasting, keto diet, and several other things which he sees, but he has no time for regular exercise. There has been a TikTok study of 67,000 health talks which tell us that only 2% are accurate. So we are not quite sure whether what he's doing, looking at social media, is actually going to help him lose weight and get a better lifestyle. Now, this is what the ultrasound shows. This is just to, not his ultrasound, but just to show you what an ultrasound will show. It will show various grades of fat, grade 1, grade 2, grade 3, depending on the echogenicity, whether the portal vessels are obliterated, and whether the diaphragmatic outline is obliterated. And accordingly, it's labeled as grade 1. So you see a hyperechoic liver. Hyperechoic means it looks more white on ultrasound. And the problem is that only if there is more than 30% of fat in the liver, that it will get picked up by ultrasound, which means smaller amounts of fat will not get picked up on ultrasound. Now, this is his body composition analysis. If you see, this tells us how much is the fat mass in the body. It's a very useful test, very easy, and a very reasonably costed test. So, it will tell you the fat mass. It will tell you how much is the fat in the visceral organs, which means the vital organs like liver, pancreas, heart, etc. And it will tell you how much is the muscle mass. So it's a very useful test which we often use. Now, if you can see here, this thing in yellow is an important thing. It tells us about the visceral fat and it gives a value of 15. So anything up to 10 is an average fat, 10 to 15 is high fat, and anything more than 15 is very high fat, very high visceral fat. So his is bordering on the very high visceral fat, and that is not a good idea because we know that visceral fat correlates with insulin resistance, with heart disease, and several other diseases of the metabolic syndrome. When we come to his fibroscan, now this is a test done to find out whenever somebody has a fatty liver with high enzymes or has components of the metabolic syndrome, like this person had diabetes, dyslipidemia, hypertension, a fibroscan is recommended. And this fibroscan gives us two values. The first value is the CAP value, which is controlled attenuation parameter. It is the amount of fat. Normally, it should be less than 240. His is 347. So that is S3. S stands for steatosis of fat. S3 steatosis. Normally we have S0, S1, S2, S3. So his is extreme form of fat in the liver. It not only tells you about the amount of fat, but it also tells you about whether there is any scarring or fibrosis happening in the liver. So you can have anything less than 6 would be normal, and anything more than 12 would be suggestive of a cirrhosis. So you have F0, which is no fibrosis, to F4, which is cirrhosis. Anything which is F2 or more tells you that there is significant fibrosis. Now his is F1, first degree of fibrosis. So he had started getting scarring, but it is early scarring. So he has a lot of fat and early scarring. Now he tries to reduce weight following the written advice of the dietitian. Also tries to join a gym but is unable to sustain beyond the first week. He finds it quite boring and he cannot tolerate the loud music. He manages to reduce just about 2 kilos in 6 months, and his BMI from 29.7 is on 29. Now, as you know, in India, any BMI more than 23 is considered. BMI, as you know, is calculated from height and weight, and any BMI above 23 is taken as overweight, and above 25 is taken as obese. So he is in the obese category. His hemoglobin HbA1c does come down from 7.2 to 6.8. Enzymes are a little better, marginally better lipids, but still not perfect. Is it possible to implement? Now he comes back to us and says, what do I do? I've tried everything, but I'm not able to really reduce weight. He even asks us whether he can use Ozempic, which is the injectable semaglutide, or Manjaro, which is a combination of GLP-1 and GIP. So, so the question is, which is tirzepatide. The name of the drug is tirzepatide. So, because he's heard a lot that many people are taking this and you can instantly get your weight down. Or do you think I need bariatric surgery is what he asks us. So the problem is now, is this patient going to go from the liver doctor to the physician, endocrinologist, nutritionist, physiotherapist, psychologist, and a bariatric surgeon? So all these people, these kind of patients tend to go from one doctor to the other, often in different hospitals, trying to sort out various problems. And really, all this is actually part of one syndrome. So, just a little bit of theory now. What is fatty liver? So, whenever there is more than 5% fat in the liver, it is called a fatty liver. Normally, the liver should have less than 5% fat. But if it's more than 5%, it's a fatty liver. So this patient obviously has more than 30% fat, which we know. So there is a fatty liver. Now, what are the causes of fatty liver? It could be because of alcohol, could be because of non-alcoholic fatty liver disease. Now, this is a condition which is being diagnosed more and more and is now becoming the commonest cause of chronic liver disease or cirrhosis. Even if somebody rapidly loses weight, it can cause a fatty liver. And there are several other diseases like hepatitis C, Wilson's disease, or several drugs which I have named here, which can cause fatty liver. But what we are interested in is non alcoholic fatty liver disease, which incidentally now has a new name. Now, this is becoming epidemic, so to say. 1 in 3 Indians suffer from fatty liver disease, and even globally, these are about similar figures. So, why so, and what can be done? So, if you look at the spectrum of non-alcoholic fatty liver disease, you have a fatty liver, which is more than 5% of the fat, where there is only fat, and this is referred to as steatosis. Then you have steatosis, that is fat with inflammation and fibrosis. We call it NASH or non alcoholic steatohepatitis. And when scarring develops, what is called fibrosis, and becomes extreme with nodule formation, it is cirrhosis. Now, this cirrhosis can remain compensated for a time, which means the patient has cirrhosis but has no clue. Many patients of cirrhosis may have no symptoms, may even have normal liver function tests. So, just because the liver function tests are normal and there are no symptoms does not mean that you ignore a fatty liver. During the COVID pandemic, when a lot of patients were getting their CT of the chest done for the COVID, so many were diagnosed incidentally to have cirrhosis. So, the moral here is that do not neglect any fatty liver, especially if you have been overweight, especially if you drink alcohol, or especially if you have other components of the metabolic syndrome like diabetes or hypertension, as in this case. Incidentally, he was only 25-year-old and he had already hypertension, diabetes, dyslipidemia, and probably obstructive sleep apnea because he was snoring at night. So, this can remain silent for many years without any symptoms, and then after many years, it starts decompensating, developing various complications like ascites, variceal bleed, encephalopathy, and can also progress to developing a hepatocellular carcinoma. And in fact, it has been seen that for hepatocellular carcinoma to develop, you don't really need cirrhosis. Even in a severe state of steatohepatitis, which is the stage prior to development of cirrhosis, one can develop NASH, one can develop a hepatocellular carcinoma. So, what is the new term for non alcoholic fatty liver disease? It has been now labeled as metabolic dysfunction associated steatotic liver disease. And it's a new term. And the word fatty was thought to be detrimental, which patients did not like. And hence the term steatotic was introduced. And it was called the term alcoholic. In the term non-alcoholic fatty liver disease also was seemed to be objectionable, so it was replaced by metabolic dysfunction because we know that it's part of the metabolic dysfunction. It is just a tip of the iceberg. You can have central obesity, dyslipidemia, diabetes, hypertension, all as part of this metabolic syndrome. And so, when you have a fatty liver, you need to look for all this. We know that 90% of diabetics will have a MASLD or a NAFLD, as is being shown in various studies. So, how can one suspect that somebody may have a fatty liver? Now, this was our patient. You can see that he had this kind of black pigmentation, hyperpigmentation over the neck, which is referred to as acanthosis nigricans. It is a sign of insulin resistance or the metabolic syndrome. And if one has this, is a good chance that he will have a fatty liver. Also, we know that in India, the kind of obesity which we see is centripetal, where the waist circumference is more. Anything more than 80 centimeters for females and more than 90 centimeters for males is considered as a high waist circumference, and this patient had a waist circumference of 104. So ask for a family history. Now, so because as I said, you can have various other medical problems associated with it. There could be a cardiovascular disease in the family, there could be hypothyroidism, there could be hyperuricemia in a female. Ask for polycystic ovarian disease, diabetes, obstructive sleep apnea. All these can be there in the family. And if you have a family member, which we went back to this patient and asked, his father has diabetes, his mother had hypertension and heart disease, and his grandparents also from the mother's side had diabetes. So there was a strong family history. There are a lot of genes which have been associated with this disease. So a familial history is extremely important. So anybody who is overweight as a child, it's typically picked up in adolescence. If there's a adolescent who is overweight, and or a young man like him who is overweight, ask for family history. If there are any of these risk factors, this person should be investigated for a fatty liver and for all the other illnesses which are associated with the fatty liver. So how does one get fatty liver diagnosed? As I said, most of them are asymptomatic. As was this patient, it got diagnosed on a health checkup. But sometimes they can come with right upper quadrant discomfort, which is because the fat kind of puts a stretch on the liver capsule, which gives the discomfort, which is typically seen. It's a dull pain. It's not a pain like a gallstone colic, because often these patients have associated gallstones. So one has to differentiate the two. And or you may get a incidental fatty liver. You're investigating with an ultrasound for some other reason and you find a fatty liver, or there may be abnormal liver tests where it can be diagnosed again on health checkup or for any other reason when the tests have been done. Or you may have a patient who's come with other illnesses like diabetes, heart disease, and gets diagnosed to have a fatty liver. Sometimes the patient straight develop cirrhosis and present with cirrhosis, or present for the first time with hepatocellular carcinoma. So they can be diagnosed in various ways. Incidentally, in a patient who has steatosis and progresses to steatohepatitis and cirrhosis, the commonest cause of mortality in a patient of fatty liver is ischemic heart disease. So always look for cardiac problems in these patients. Also, patients who have a fatty liver, the second commonest cause of mortality is malignancy. And I do not mean necessarily hepatocellular carcinoma, it could be any malignancy. It is well known that people who are obese have a higher risk of malignancies, any malignancy in the body, and so also for fatty liver. And the number three cause of mortality in these patients are liver related or cirrhosis related complications or hepatocellular carcinoma. So, how can we prevent progression of NAFLD or MASLD? The mainstay is lifestyle, and whatever drugs we have in the market, unless there are lifestyle modifications, the drugs are difficult to sustain long term, are pricey, and have their own side effects. So, lifestyle modifications, there's no excuse to escape this, and I will indulge more on the lifestyle modifications. There's really no role for herbal supplements, colon cleansing. Various supplements have been used, but not proven in scientific studies. So, what weight reduction do we advise? Not around 1 kilo a week is a reasonable weight reduction. There should be no crash dieting. Now, what happens when you lose weight? How does the fat in the liver or the scarring in the liver improve? So, when a person loses 3% of the weight, the fat comes down. When there is 5 to 7% reduction in the weight, the steatohepatitis reduces. And when there is more than equal to 10% of weight reduction, the scarring or the fibrosis starts getting better by one stage. So this patient has, we will see now what happens when he loses weight. So we expect or we hope that at least he's got NASH, he's got high enzymes, he's got a fair amount of scarring in the liver, first degree of scarring in the liver, and he's got a huge amount of fat in the liver. We haven't done a liver biopsy to see whether there's steatohepatitis because his liver enzymes are high, and we have done all other tests to rule out other etiologies of his abnormal enzymes. So, diet and exercise. So, we calculate the ideal body weight, and the diet should include 25 kilocalories per kg per day of the ideal body weight. 40% of these should come from carbohydrates. There should be more protein. Why? Because when one tries to lose weight, also in addition to the fat mass, the muscle mass also reduces. And as I showed you on the body composition, we look at the muscle mass. So the challenge is to lose weight by losing fat, but not by losing muscle. And less than 30% should be fat intake in the diet. The saturated fat should be even less. Saturated fat like dalda is a saturated fat. Now, how do you know what is his ideal weight? So his height, say, is 167 centimeters. You minus 100. So his ideal weight is 167 minus 100. This is a good bedside way to know what is the ideal weight. So his ideal weight is 167 minus 100, that is 67 kilos. So what do we do? There are, of course, weight calculators which you can go on Google and calculate based on age, gender, and give the height and ask for calculation. And there are several formulae. But the easiest way, as I said, if you want to quickly tell a patient how much he needs to lose weight by the bedside, just subtract the height in centimeters minus 100. There are now, what is the dietary advice you give them? Now, there's so much talked about diet, but one simple advice: avoid snacking. People think that when they have snacks, it's like you're skipping a meal, and snacks will be low on calories, and therefore it's more healthy. But no, snacks can be very high calories and should be avoided. Now, general advice: cut down sugar. We know that whatever earlier we used to blame fat, but more than fat, it is the sugar in the diet which is a problem, because we know that sugar gets converted to fat in the liver. So, completely reduce sugar, wheat, all the processed food. What do you mean by processed food? Any food which is simply available in a packet or a bottle, avoid. So anything which is ready made juices, ready-made Pepsis and Mirandas, anything, bread, biscuit, cakes, pastries, everything needs to be avoided, and individualize the diet. So you sit with the patient, the dietitian or nutritionist sits with the patient, tells him asks him first what he has for breakfast, lunch, dinner, and based on that person's diet, modifies the diet rather than giving a standard diet to every patient, because we know there's so much of variability in different communities and different regions of India. Now, adherence to diet is a challenge, and therefore, there we sometimes use a psychologist. And I'll tell you about a program which we had at Jaslok Hospital, which is quite successful. Now, do you give small, frequent meals? Do you ask for intermittent fasting? Do you give a Deveka diet who insists on homegrown food, the food which our grandmothers ate, or do you give a Dikshit diet who talks about intermittent fasting? And there's so many name diets: Atkins, keto, Mediterranean. So, which one of these are good? Now, what has been proven in literature is Mediterranean diet. Now, what is Mediterranean diet? Mediterranean diet is mainly lots of vegetables, salads, nuts, legumes, what you can see in the picture. Now, things which are rich in omega 3 fatty acids, which is fish for non vegetarians, walnuts are good on omega 3 fatty acids, and good amount of protein. They talk of olive oil. We know that Indian cooking is not really suitable. Olive oil is not suitable for Indian cooking. You can use the extra virgin for salads, but for regular Indian cooking, where food is cooked and in oil for quite some time, olive oil is not the best. And there's an Indian modification, the mustard oil. So mustard oil can be used. One can rotate it with rice bran or sunflower oil. So, but mustard oil is a good oil to use because it is rich on omega 3 fatty acids. And avoid crash dieting. What about exercise? Now, one has to do cardio and resistance exercises, both these. Now, what does cardio mean? Cardio is an exercise which, like swimming, running, jogging, all these are cardio, where your heart rate increases and therefore there's an increased calorie utilization and person loses weight. It could be a moderate intensity or a high intensity exercise, and one has to get a target heart rate. Now it's mentioned here what moderate is, what high intensity is. If you're doing high intensity, you can cut down the amount of time because you're utilizing that many calories in a shorter period of time. Now, maximum heart rate is calculated by 220 minus age. So, if he's a 50-year-old, his maximum heart rate is 170. And if you're doing moderate intensity, so 170 into zero point 0.7 will be the target heart rate. So, that is the heart rate he has to maintain and not try and go above it if he's doing a moderate intensity exercise. Now, there are also resistance exercises. Now, these are exercises like strengthening, weights, therabands. These are resistance exercises which increase muscle mass. They may not help as much in losing weight, but they will improve cardiovascular fitness, improve the hypertension, diabetes, dyslipidemia, and the steatohepatitis. So we need a combination of cardio and resistance exercises. Now, what is NEAT? NEAT is non-exercise activity thermogenesis, a big name, but basically means energy which we spend in our day-to-day activities, which are not necessarily a regular exercise. Like for example, if your office is on the fifth floor and you say that you don't have time for exercise, go climb stairs, avoid the lifts. So it's a part of your daily activity which you can incorporate in your work schedule. Carrying groceries rather than taking a, you're going 10 minutes away, you can carry your groceries back home, walk back home rather than taking a cab or a bus. Mopping the floor, washing dishes, ironing clothes, all the household chores would be neat uh, and will also make you spend enough energy. Screen time is something which has been shown to increase. Higher the screen time, higher is the chance of developing a fatty liver, because you are basically sedentary, there's not much activity. And actually the Indian Academy of Pediatrics has given guidelines, because the whole thing is that the habits have to be inculcated right from early childhood. So we know that little children, when they're not drinking milk, are shown the mobile and some cartoons, and they watch cartoons and are having their milk or food. And it's easy, it's a good shortcut. Mom is working, father is working. So there are some guidelines based on age, as I've mentioned here, where one has to basically try and cut down the screen time. Make children instead go down and play, a habit which is now almost lost. Now, this patient also asked us, are there any liver tonics? Really, no. There's so many liver tonics in the market, but none of them have been proven to have any scientific evidence in reversing fatty liver or steatohepatitis. What about drugs? Now, there are some drugs which have been tried, like vitamin E, saroglitazar. Saroglitazar was a drug which was used in treatment of diabetes and dyslipidemia, used in the dose of 4 milligram per day, and has been approved for use of fatty liver, some role in reversing fibrosis. But we are awaiting, that's only in India it has been approved, but not abroad. Now, resmetirom is a drug which a THR beta agonist. Basically, it increases the BMR and therefore reduces weight. It has been approved. It was the only drug approved in 2024. Very recently, semaglutide is a drug which was being used for weight loss or for treatment of diabetes, but now has been approved for use of NASH, non-alcoholic steatohepatitis, or now it is called MASH, metabolic dysfunction associated steatohepatitis. So semaglutide, resmetirom, vitamin E, saroglitazar are the approved drugs. Now, semaglutide can be used as an injectable or oral. These drugs are not without side effects, and the patient needs to be, what should I say, adequately warned about the side effects. Maybe, and whenever these drugs are to be used, one has to incorporate a lifestyle. So you cannot simply, a patient comes to you like this, straight away start him on a drug like semaglutide. he needs to follow lifestyle modifications because he's so young. For how long is he going to use this drug? And start off with lifestyle, give a trial and see, and then if required, add on lifestyle to the drug. What about bariatric surgery? Bariatric is typically used in BMI more than 40. In India, BMI more than 32 with a poorly controlled diabetes or obesity related comorbidities can become an indication for bariatric. And of course, weight loss will improve insulin resistance, liver function, and everything else. But in this patient, he's not a candidate for bariatric surgery. So, coming back to him, we enrolled him in a fatty liver program which we had at Jaslok. We made him stop alcohol. He was vaccinated for hepatitis A and B because his antibodies were negative. He did not remember whether he must have got, being 25-year-old, hepatitis B vaccine, but the antibody titer was low, so he was vaccinated for B as well. A is not part of our universal immunization. He got vaccinated for A. He lost weight, 10 kilos in 3 months. His BP got corrected. He had started off with a dose of 5 milligrams, came down to 2.5 milligrams of amlodipine, and was not needing any medications for his diabetes and dyslipidemia. HbA1 of 5.9 from 7.2, and his lipids also significantly improved. His vitamin D deficiency, which was there, got corrected, and he had a moderate OSA, obstructive sleep apnea, on the sleep study. He was very reluctant for CPAP, but the parents and his friends said that he had stopped snoring after he had lost weight. So this is the fatty liver program I was talking about, and about how this is a program which has incorporated multiple disciplines under one roof, where every, and it's a 3-month program with the nutritionist, physiotherapist, and a psychologist at the helm of affairs, because the physiotherapist made him exercise with monitoring. So it was better than going to the gym because his blood pressure was high. So his BP, pulse rate, target heart rate, everything was being monitored and escalated. Exercise was accordingly escalated. The nutritionist, there were 4 sessions with the nutritionist through the 3 months, where a diet chart was maintained, and he reported back about where he was able to manage and not able to manage. And you may be wondering why a psychologist. And we realize that a psychologist is actually the most important part of the program, because psychologists will analyze your eating behavior, will see when is it that you're not able to control the eating, and when is it that you go and binge. He was having late nights, he was not sleeping on time. Sleep hygiene is extremely important. It has been very well shown that those who sleep late, those who do not sleep 7 to 9 hours in a day, their fatty liver progression is much faster. So, sleep has been ignored but is a very important component. And he was also having obstructive sleep apnea. So, he was explained the sleep hygiene, and all this was done with the psychologist and the physician in the study. And look at his fibroscan. From a cap which tells you about the amount of fat, from 347 it was down to 273, still not normal but much lower. And his fibrosis was F0 now, from 6 to 4.6. So that had improved. His visceral fat, which was 15, is down to 11. So that also has improved on the body composition analysis, and his muscle mass had also improved. So he was counseled about potential need to continue lifestyle modifications. He joined a popular yoga online yoga program because he said he could not step out, but he managed to swim 3 times a week, which gave him swimming gave cardio as well as strength exercise. He used various apps to count his calories, and he used to live with friends. So he switched to a healthy diet, and his friends also, along with him, switched to a healthy diet when they saw the dramatic transformation in him. So I would like to conclude by saying that really, for fatty liver disease, the most important thing is prevention. We know that all diseases begin in the gut. This was said by Hippocrates, because you know that gut has many bacteria, millions of bacteria, and these could be good bacteria and bad bacteria. The good bacteria come if you are eating healthy, bad bacteria if you're eating unhealthy. And it is said that when a woman gets pregnant, it is in pregnancy or even before pregnancy where she needs to be healthy before getting pregnant. If she is healthy, eats healthy during pregnancy, the child who's born will have a healthy gut, a healthy microbiome, what is called a gut microbiome. And the gut microbiome of the child will determine what diseases he or she has in future adult life. So I would like to end by saying all diseases begin in the gut and look after your gut. Thank you.
Yeah, thank you, ma'am, for such insightful presentation, ma'am. You have shed light on a very relevant and practical issue, helping us to better understand and the approach to incidentally directed fatty liver. We now move on the Q&A session, ma'am, where we can take questions from the audience. Okay.
Sure. I'm
So
not
the
able
first,
to see. I'm not able to see. I think I'll just listen to your questions.
okay. So the first question is, what is the recommended frequency for monitoring LFTS and imaging in patients with incidental fatty liver?
So it all depends on. So, if like in this patient, if you have abnormal LFTs and we have said, okay, you follow the advice. So many people like this patient managed to get his, weight under control. His exercise was regular, his diet under control. In him, I would do it after 6 months or maybe after 3 months because we repeated everything after 3 months. But if the patient is not able to lose any weight, there's no point in really repeating after 3 months. I would say, okay, go back, lose weight, and then come back after 3 months. So it's variable depending on how high the LFTs are, how motivated the patient is. Sometimes we do it more frequently, even if the patient has not lost any weight, to just kind of show the patient that, look, you're not getting better, your LFTs are getting worse. But I can tell you one thing, just because LFTs are normal does not mean that there is no cirrhosis. So don't just go by LFTs, as I said. So if there's a fatty liver, you have other comorbidities, get a fibroscan done, and that will give you a true picture of what the liver function is like.
Okay, ma'am. Thank you for the answer, ma'am. And I'm taking to next question. The next question is, how do you track progression from fatty liver to NASH or cirrhosis in an otherwise healthy individual?
So NASH, which is steatohepatitis, or MASH, which is metabolic dysfunction associated steatohepatitis, that's a new term. To cirrhosis, we can do an ultrasound, but ultrasound will pick up these changes much later. So there are tests which I showed you, like a fibroscan, and you can do even some people do MR elastography, but fibroscan is much easier to do. There are certain formulae also based on some liver tests which can tell you whether there is likely to be scarring or not. There's something called the APRI score, APRI. There's several scores. FIB4 is another score, FIB4. So one can do, just put in values of your liver function test, etc., platelet count into the Google sheet, and get the scores, and that will give you an idea of whether there is scarring happening or not.
Okay. Thank you for the answer, ma'am. And I can see there is a two question is left. So the question is, what red flags should a general practitioner look out for in follow-up visits? How do you counsel an asymptomatic patient who may not feel motivated to act?
So I think so. If for a general practitioner, as I said, if the waist circumference is high, if there's a black hyperpigmentation on the neck, this is a chance that very high chance that he has a fatty liver. Go back to the family history. As I said, in this patient, his parents, his grandparents, all had some part of the metabolic syndrome or the other. So this is in adolescence itself. That's when it starts getting picked up. start counseling the family about healthy ways of eating, about regular exercise. And I think the earlier we start, the better it is, because somebody has a fatty liver at the age of 13, by age of 30 he is likely to have cirrhosis. So it's very important that the counseling starts early, and the family physicians are actually in the best position, because they have seen the family, they see how parents are the family members all obese, do they have these medical problems which I'm enumerated. In that get the whole family to follow a particular diet, get monitor their if they have fatty liver on ultrasound, even if their liver function tests, if they are either abnormal or if they have any other illness like diabetes, heart disease, ischemic heart disease, get the fibroscan done or calculate a FIB4 or a APRI. And if there is scarring, if there is significant fatty liver on the fibroscan, I think get them to get into an exercise diet program. And if in spite of that the things are not coming under control, then one will need to resort to one of the drugs which I mentioned.
Okay, thank you for the answer, ma'am. I hope you did justice with the answer. So the last question is, when should pharmacological interventions, example vitamin E, GLP-1 analogous, SGLT2 inhibitors, be considered?
Yeah, so whenever there is significant fibrosis, okay, so on a fibroscan, if it is F2 or more, this patient of ours had F1 fibrosis, so we didn't put him on any pharmacological therapy. Whenever there is significant fibrosis, now SGLT2, yes, that is dapagliflozin kind of drug, can also be used in addition to the drugs which were mentioned. There's more and more data on it being useful, but give it only when there is significant fibrosis. Vitamin E, little role in fibrosis, more for steatosis, but I would say resmetirom, saroglitazar, and the GLP-1 agonists have been shown to reverse fibrosis as well. So F2 fibrosis, and patient has given a good trial of lifestyle. So continuing the lifestyle measures, one of these pharmacological agents can be added.
Okay. Thank you so much for the answer, ma'am. I hope you did justice with the answer. So, with all your permission, I'm going to conclude this session, ma'am. So, thank you so much, ma'am, for sharing such valuable insights. Your practical guidance and expertise truly help us to understand these things. And on behalf of MedTalks and IDCP, I extend my heartfelt thanks to ma'am for sharing her valuable knowledge with us today. And thank you all to attendees for your participation. Stay tuned with MedTalks for more such
Thank you.
engaging sessions. Thank you, ma'am. Have a
Thank you.
nice evening. Okay.